أروى
مرحبا بك يا بروف.
خلاص الصورة واضحة.
الصورة واضحة والصوت واضح، ممكن نبدأ.
طيب. Welcome to this lecture on the series of lectures of infectious and tropical diseases. You remember last time we discussed how we started as tropical diseases, but later we converted it into medicine in the tropical. Instead of tropical diseases, we started medicine in the tropics, meaning that the diseases which are restricted, geographically restricted, tropical areas are minimal, okay? And we gave examples of trypanosomiasis, which is very much linked to the vector, onchocerciasis, which is again linked to a vector. But on the whole, other diseases has been prevalent in the temperate climate in the Mediterranean, like malaria, schistosomiasis, others. And the argument went into the fact that we are not dealing with a parasite or a bacteria as much as we are dealing with an environment where the patient is and who is the patient. For instance, if you have a malnourished patient or a patient with deranged immunity, then the disease will manifest differently, and more diseases will attack those patients of malnourished. So it's and apart from malnutrition in the tropics, we have overpopulation, overcrowding, instability, wars, snakes, whatever. These are the factors, socio-economic factors, which are accumulating their effect and their impact on the human and making diseases like infections, dysentery, because of the environment, because of the sanitation, because of lack of potable water. All these are cumulative. So it's medicine in the tropics or medicine in the tropical area. Having said that, I just wanted to broaden your ideas about pathogenesis and pathology of diseases and the impact of diseases. Recently, we had a chance with HIV/AIDS, which is a disease, a viral disease that suppresses immunity of patients and has uncovered a lot of infections, a lot of bacteria, and a lot of fungus. Things like cryptococcal meningitis used to be not common. With HIV, it is very common. Tuberculosis, which is mainly restricted in poor areas and poor environment of the tropics. Now it's widespread in Europe and America. So it is a composite problem. And I think by and large, most of the diseases have multiple reasons for their pathogenesis and their intensity and the prevalence and the prognosis of the patients. If you are fit, immune competent, then your chances of coming out of the disease is higher, much higher than if you have a patient, if you are a patient who is immune compromised, be it by disease or be it by drugs. So I would like you to accompany me with this concept of disease. I would like to recall a saying by somebody called Stewart. It's what we call Surgeon General of America, of the United States. And in 1969, he said, well, he was boasting. He said, well, you know, with the decline of tuberculosis in USA, he said, now we are going to close the book of infectious disease. How ignorant that man was, because then diseases of infection has even increased in many parts of the world. not sparing United States of America. So scientists should always be modest, And fuqaha diamond, when they are asked about something in religion, they say, Allahu A'lam. So science is about modesty. Okay, today is the 24th of March. Remember? 24th of March, 2024. This is exactly the date when Robert Koch in 1882 discovered Koch bacillus or tubercle bacillus. So it is 142 years, exactly this day, that when he called the Physiology Society and he announced that, look, gentlemen, scientists of Germany in Berlin, I have discovered the bacteria that causes what is later known as tuberculosis. So that was a major discovery. Not only that, but he went on to tell us, or tell the society then, that this disease can be spread from one person to another. And he purified a protein, PPD, purified protein, which is used nowadays for the test of MAN2, which will tell you if the patient has or is in a state of tuberculosis. So that person, was a genius, I think, but he was not only, he didn't come from the sky, he was working hard to come to that conclusion. So this lecture, in the memory of that discovery, it is going to be on tuberculosis. It's a very common disease, and it cuts across all specialties, not only pulmonologists who are there, diabetologists, are affected, and bones, when you have pulse disease of the spine, pelvis, genitourinary affected, the eye with choroid nodules are affected, even the skin, lupus vulgaris, are affected by tuberculosis. So it's a disease which is can spare no cells or no tissue in the body. So it is important. And there are two important aspects in the history of tuberculosis. Number one is the discovery of streptomycin, which is a specific drug it's an antibiotic, but has been shown to be very effective in tuberculosis. And this route has developed later into development of rifampicin, which is an antibiotic, INH, isoniazid, which is very specific to it's a tuberculostatic, and other second line drugs has been introduced. So this is part of the history and has converted the disease from a stigma to a disease which can be cured. So that is one landmark in the history of tuberculosis. The second is in the 80s, when HIV came into the scene, it showed us experimentally, if you lift up the immunity from the body, what do you expect? And there we were shocked, not only shocked, but we were surprised by the fact that the body is really strong by a strong immunity. Okay, we are in constant attack by bacteria, viruses, but our immunity is so strong that we can stand up to it. If you just look about the number of bacterial viruses which attack the body, you wouldn't believe that we can survive. But because of the immunity, I give you an example. HIV/AIDS is a very, very virulent virus, very virulent virus. But when it goes in, when it goes in, the body attacks virus so strong and so much that it is kept, in hiding, okay, for years, up to 9 years, okay. Here it is multiplying, but the body is attacking. So it did not go out of control. But once in that time when the body is either immune compromised further by any other factors, or by the exhaustion of the immunity after 9 years, 10 years, then the disease becomes over. This is a fact which is very well exemplified by tuberculosis. Tuberculosis has been known to be a disease which gives an example of how strong the immunity of the body is. Okay, and any factor which will decrease the immunity or interfere with the immunity will increase susceptibility to tuberculosis. Okay, if we go into these factors, number one is obviously HIV/AIDS, which is increases susceptibility by multiple times, almost 8 times, if you compare it with immune competent individuals. Okay, diabetes, okay, which is again affects the immunity. It increases the susceptibility of patients to get tuberculosis by triple, by 3. Okay, other factors, which will decrease the immunity, like corticosteroids, very common, immunosuppressive. If somebody has cancer, he runs the risk of getting reactivation of tuberculosis. Okay, and renal failure, end-stage renal failure is another cause of increased susceptibility. Tobacco, cigarette smoking. Now there is very good evidence that patients who smoke, especially heavy smokers, are more susceptible to get tuberculosis. Get that in your mind. I think it's important to remember. Alcohol dependence. Okay, you drink small amounts, it's okay. Not okay, but I mean, it doesn't affect the immunity and susceptibility to tuberculosis. But if you drink like up to 30 grams per day, then that will give you susceptible individual. Okay, so these are the factors which will increase the susceptibility to tuberculosis. Why are we going to say susceptibility? Because we think that during childhood, tuberculosis got into our bodies, especially in high prevalence areas of tuberculosis. That is a fact. And it goes in, and then it got trapped by mononuclear cells, okay? And it remains in those mononuclear cells as far as the immunity is competent. Then this is kept in dormancy. It's called latent microbacteria or hiding microbacteria. But now the evidence shows that these bacteria are multiplying very slowly. And the immunity is attacking that. Whatever it comes out of that, of its springs, it gets attacked by the immunity. Okay, we'll come to where the primary focus, and then the primary complex, what we call cons focus, and then we see how this is reactivated into a full-blown tuberculous disease. Okay, so I would like you to get the impression that we are talking about tuberculosis in hiding or latent and open tuberculosis. And open here is not only in the lungs, but overt. Overt, it comes out as a disease. Okay, what is the bacteria? The bacteria is Mycobacterium tuberculosis. This is the human tuberculosis. Okay, and it used to be tubercle bacilli, but in 1986, 4 years after Koch discovered the bacteria, it was officially scientifically labeled as Mycobacterium tuberculosis. What are the other bacteria or tubercle which can affect man? It's bovis. And bovis is related to cattle. Remember, we have Schistosoma bovis, which is in cattle, and now we have Mycobacterium bovis, which again in cattle. And here, the infection is not through the aerosol, it is by drinking contaminated milk. This is why what we call pasteurized milk. Pasteurized is not boiled milk. It's warmed up to a certain level, which kills the bacteria. If you go to a supermarket in Europe and you buy milk, it is pasteurized milk. It is not boiled. But luckily in Sudan, we are very fond of boiling the milk. If you boil the milk, you kill quite a lot of organisms, including tubercle bacilli. Okay, so it's the other bacteria is Africanum, Africanum, which is human tuberculosis in West Africa, but not very common. Others are depending on the species. If you can get Capri tuberculosis or Mycobacterium capri, Caprae, capri, and this is in goods, but it is not infective to human. So let us concentrate on Mycobacterium tuberculosis, which is the main tubercle bacilli affecting man. It's only a human tubercle, and we concentrate on that. Okay, so these are, as far as the bacteria is concerned, it's an airborne. It's an airborne when you have an open. When we say open, scientifically, it means, open tuberculosis, meaning that it can transmit to other areas, okay? Or you can reach it. You can reach it not by putting your hands, but it reaches you when people cough, all right, or breathe. Then the nuclei or the droplets is being aerosolized, being in the air, and you can inhale it. It's what we call droplet nuclei containing the bacteria. And there is a lot of talk about the mechanisms and the how the air can take the droplets. Okay, if you obviously it comes out with some water, and then this gives it some protection, and it goes far. And they said even if you talk loudly, somebody who is in open tuberculosis, if he speaks loudly, then he can disseminate these droplets, nuclei with tuberculosis. Experiment has been done. If you localize some people with tuberculosis in a room, okay, with some normal people, the attack of tubercle bacillus is higher because the dose in the air is higher. If you take this air of patients, breathing, just breathing, you take it to siphon it into an area where there is animals, or this is an experiment where there is hamsters or mice. These mice will get tuberculosis. So it is a scientific fact that these patients are infectious and are dangerous. However, the stigma of tuberculosis has been very much less. Tuberculosis, before the advent of drugs like streptomycin, used to be a stigma. families with the patient with tuberculosis are not being uh, married to. They cannot be eat. They don't eat with them, and it is almost labeled in the area that this house is a tuberculosis house. And they used to be locked in sanatorium, okay, quarantina, sanatorium, where they're being given some drugs, most toxic drugs, not very effective drugs, but they are being kept there in these areas. Until recently, Sobo Hospital, I'm sure you know it, Sobo Hospital in outskirts of Khartoum, was built by the Russian as a sanatorium, as a as a uh, chest hospital, mainly for tuberculosis. But the physicians, chest physicians then, refused it. And this is why University of Khartoum jumped into the wagon and took the hospital and their teaching hospital. So it used to be a disease in sanatorium in areas where there is patients are just kept alone, they are not being visited so often, and they just leave themselves. Okay, we still have a Burangia hospital in Sudan. Okay, these are patients who have complicated tuberculosis. Okay, because nowadays we treat tuberculosis as an outpatient, and the patient, if he takes the drugs, which are now very effective and very good, and by and large are safe, by 2 weeks, the patient will become non-infective. If you give them for 2 weeks, the patient becomes non-infective, which is a major epidemiological index. Because then, I mean, if you keep them too long, then you are almost keeping the patient idle, not working, and so on. But patients are mobile, and when we talk about treatment, we are going to talk about DOTS, which is direct observed treatment. Direct observed treatment. They come 2-3 times a week to the clinic, and they take their drugs, and they swallow it during the day, and they just go. So the message here is we are turning tuberculosis, the uncomplicated, into a disease which can be treated as an outpatient. Infectiousness is very dependent on the load of tubercle bacilli, and the infectious rate is increased if you have low immunity. Like patients with HIV/AIDS with tuberculosis are more more effective. Okay, so it's that important to remember that if you are in a clinic, with patients with tuberculosis, open the doors, and it has been shown that this is an epidemiological finding that less transmission occurs when you have the air being changed from inside to outside. So that is about the bacteria. Okay, it is when it is out, all right, when it is coughed, it can be stained by what we call Zeil-Nielsen stain. Zeil is Zeil, Nielsen stain, Zn stain, and it can be cultured. It can be cultured. So the ultimate is seeing the bacilli, which is a rod. Okay, it's a rod-like bacteria, and it can be cultured, and then that is the proof of what beyond which you don't need any other proof. Um, the disease is prevalent in many parts of the world. It's mainly in, say, Africa because of the HIV/AIDS, because of malnutrition. And we said that this increases susceptibility, and because of overcrowding in many parts of African countries, the overcrowding leads to the infection. Okay. In WHO in 2020, okay, recorded that there are 10 million cases worldwide, and deaths or mortality is about 1.2 million. So it's still a disease which is need to be looked at very, very carefully. And the importance of the disease now is HIV. It's now in many hospitals in Africa. There is a department, complete department for HIV, AIDS, tuberculosis, and what they call community medicine or community or public health. And these hospitals receive for a particular department, and there are physicians who are very specialized in that, is for tuberculosis and HIV/AIDS. Definitely, if you have ART, okay, retroviral therapy, the combined, then you will have less infectiousness and less liability to get tuberculosis. So the treatment, antiretroviral therapy, is extremely important to be taken. And as we have said repeatedly, that HIV/AIDS is becoming a chronic disease. It's not curable, but it can be contained into a very low level of treatment or infective or disease. Okay, the problems with HIV, with tuberculosis, is treatment. Okay, it's a long treatment. Okay, it used to be 2 years, 3 years, but nowadays it's it's 9 months. And if you give multiple therapy, four tablets, you can go up to 6 months. Okay, so it is a disease which is very much dependent on the number of tablets and the type of drugs you are using. Okay, so we fear spread with HIV/AIDS. We fear spread by socioeconomic factors like malnutrition, overcrowding, and we supply the drugs, but with the fear of resistance. And this is an important problem. Okay, bacteria definitely, tuberculosis has, if you give it a single dose, then it can raise resistance. Okay, this is why we give 3 drugs and sometimes 4 drugs. Okay, what we fear is resistance to these drugs. This is why we are giving 2 or 3, and we have talked about combating resistance by giving multiple drugs. That is, we are doing it in malaria, we are doing it in other diseases, tuberculosis, and multiple therapy, even in cancer. Nowadays, we are using multiple therapy, which attacks the cancer cells in different areas. Okay, if the bacteria is resistant to rifampicin, which is an antibiotic, and isoniazid, which are the core of treatment, then we call this is MDR, multiple drug resistance. M, capital D, capital R, MDR, which is a signal that, we have problem, okay, in a community or in a patient. And then we go into the second line drugs, which includes fluoroquinolone, and injectable aminoglycoside, which is either amikacin or kanamycin or capreomycin. So any of those is injectable, plus the other drugs which are taken by mouth. If a patient resists one of the injectable kanamycin, amikacin, or capreomycin, or fluoroquinolone, then this is extensively drug resistant, what we call XDR, capital XDR. These are symbols or abbreviations or indications, not from my own thinking. It is an international MDR. When they talk about MDR, they are resistant to the first line. If it is XDR, it is resistant to the second line. And here, this is a dangerous situation. In Sudan, we used to have in Abu Anja a ward, okay, with pneumatic pressure, okay, takes the air outside, and even nurses will go there with caution, with masks, and they have a lot of protection, okay, with against the bacteria. Because once you have this XDR, then you are in trouble. And if you spread it, then the people around you will be in trouble as well. Okay, the clinical picture of tuberculosis is a story about immunity. It is a story about immunity because here we see that the tubercle bacilli is captured by the immune system. What happens? It's usually in children below 3 years of age. If they catch a bacteria, then the bacteria goes in and picked up by a mononuclear cells, with lymphocytes sensitized by CD4. And you remember, we were talking about HIV/AIDS, we talked about CD4, CD8. CD is a receptor on the lymphocyte. So it's a lymphocyte with a certain receptor on top of it or on the wall of it, which is named CD4. And these are lymphocytes of high quality against tuberculosis, just like in AIDS, okay, CD4. And we actually in AIDS, we measure the competence of immunity by measuring CD4, okay, by viral load or by CD4. CD4 above 200, okay, CD4 above 200, then the patient is safer, all right? If it goes down, then you are more susceptible to infection, more so susceptible to reactivation of tuberculosis and the rest of it. Okay, so what happens if it goes in? If it goes in, then it goes in the mononuclear cells, and then they have built about more attracted mononuclear cells, and they form a something like a rounded structure. Okay, the bacteria is within mononuclear cells. Around it are lymphocytes or leukocytes, and then another layer of lymphocytes, and then this is encased in fibroblasts, which is produces collagen, and this is called granuloma. This is the granuloma which you talk about, and it's a classical granuloma. Other granulomas are usually talked about when we talk about tuberculosis. Okay, so this granuloma will hide the tubercle bacilli for a very good time. Okay, and let's reactivate it. All right, the disease can be dormant for so many years, but in young children, it can, if they are malnourished or whatever, then the disease can be overt. Okay, if the bacteria is there, it causes a focus, what you call primary focus. This is the first time a child receives tuberculosis bacillus, and it rests there. Some of it will get loose and get to the lymph node. And this is the complex between primary focus, primary area of granuloma, and a lymph node not far away. It's usually in the paratracheal or mediastinum. And these two sites is called the primary focus, or what we used to call cons focus. G, capital G-H-O-N, but it is now called primary focus. Okay, this can be seen by X-ray. It can be seen easily by X-ray to see the focus and the lymph node. Okay, if everything is okay, then it remains there. All right, and it is said that in areas where there is a high prevalence of tuberculosis, most of the population has tubercle bacilli at birth, or soon after birth, below 3 years of age. Okay, can the bacilli get into a neutro baby? And the answer is yes, but rare, very rare. Okay, infection to newness usually occur during delivery, when a child may be exposed, if a mother is positive, then a child may be exposed to swallow amniotic fluid, which is infectious. So it can get an infection there, and neonates who have can have a disease. It usually isn't apparent unless after 3 weeks or 4 weeks, and the symptoms are so vague that the patient, the child, cannot drink, cannot eat or whatever, drink milk, and feels, like apathetic. The child is usually moving, but this will cause apathy to the child, and mortality is very high. Okay, in children where after neonatal period, but below 3 years, the symptoms are of a chronic nature. Okay, the child may show fever, may start grunting, like coughing, but the ESR will be very high, and there is hypoproteinemia and hypercalcemia. Okay, and the liver function test may be abnormal. The potassium may be low. So this is very difficult to get. Okay, and pediatrician, when they talk about tuberculosis, they talk about a difficult diagnostic case. Sometimes, because of the swallowing, the bacteria can be covered from an aspirate from the stomach, and do it. So it needs a lot of talent, clinical talent. Okay, the Gons focus or granuloma, the mononuclear cells, there is an interaction by CD4, macrophages, okay, and TNF, which is a tumor necrosing factor, okay, which is an alpha tumor necrosis factor, which is an alpha gene or interferon, and these are the first line of defense of these cells. As we said, CT4. Okay. After the cons focus, the chances of becoming overt in a child is only 5%. The rest of all patients who have primary tuberculosis are dormant till they are opened up for challenge by infection like HIV/AIDS or corticosteroids or the rest of it. Okay, we would have in the primary focus, in some cases, we have what we call primary progressive tuberculosis. Primary progressive tuberculosis. And this is not contained within the focus or within the granuloma. And tuberculosis that is in 5%, will get disseminated. First to the lymph nodes, and then, it eats the lungs, affects the lungs, okay? And then it may encroach on the pleura, all right? And then it becomes disseminated. This is what we call disseminated tuberculosis, or what we call primary progressive tuberculosis, to make a difference between the adult tuberculosis. And by the way, the adult tuberculosis is 8 years and above, 8 years, child, okay? Because below that, at 3 years and below, the type of tuberculosis is very much dependent on the primary focus. Okay, so it's extension of the tubercle in the local area of the lungs and the lymph nodes, and it goes to other places. Okay, fever is a constant feature, but not in all people. In children, especially neonates or elderly, you can have disease without fever. Okay, but then patients will get wasted, and the Greek word for wasting used to label tuberculosis. But nowadays, we are not reaching the level of wasting because patients are being seen earlier and they are being treated earlier with effective drugs. So with dissemination, then you will have local dissemination, pleura, and the pleura could be sensitized to give you pleural effusion, or it could be encroached on and open up to give you empyema. Pericardium can be affected, and some of the lymph nodes in children, young children, paratracheal lymph nodes, can be so big to block the airway and cause atelectasis. So a disease of tuberculosis in childhood is a real challenge, Okay, so what happens later on in life when the patients becomes, adult, all right, and becomes, can receive a lot of insults from outside. Insults being HIV, is drugs, which will reduce the immunity and so on. Okay, that will be tuberculosis of adulthood, and that is tuberculosis from the one in neonates and children. Okay. Open tuberculosis, as we said by definition, is due to lungs opening, and that is the way, the major way of getting infected by tuberculosis. So the adult is termed post-primary, okay? Post-primary, all right? And the post-primary can be localized to the lung, and this occurs in 70% of cases. Okay, localized. Or disseminated. That is to say, blood hematogenous dissemination of the tubercle bacilli to other areas, all right, to other areas. What are the areas which are more prone to receive the tubercle bacilli and get infected easily? One of them is meninges, subarachnoid space, that is in the brain, tuberculoma in the brain, It can go to renal, kidneys, bones, and the bones here we mean intervertebral area. It can go to the genital, urogenital, and other places like eyes, but all tissues can be affected by the hematogenous spread. The hematogenous spread is sometimes called miliary tuberculosis. Miliary from millets, الحبة الصغير بتاعت الشعير والقمح. It's a millet. And these are when the spread of tuberculosis in the lungs, form small granulomas all over the lungs, and this gives you a look of micronodular feelings in the chest X-ray. So it's a radiographical name given to these millets, which are spread all over the lungs and giving you what we call miliary tuberculosis. But it is by no means, it is just localized to the lungs. It is a terminology which is historical, and we kept it. But hematogenous spread can be something more advanced or progressive. Okay, tuberculosis of the meninges occurs by either a cerebral granuloma, which ushers tubercle bacilli into subarachnoid space, giving you the meningitis, which is common in children. Again, with dissemination of the primary can give you tuberculosis, but in adults, it's also likely that you get tuberculosis, and this is very dangerous, tuberculosis. Okay, let us put the map of all of them, and then we come to individual description. Again, hematogenous into the kidneys, and the kidneys can be affected, tubercular, glomerular type of tuberculosis. The bones in the intervertebral disc, usually between thoracolumbar. In the thoracolumbar intervertebral disc, then you can get infection there, and eating up of the bones to get gibbous. Gibbous is a kyphus. You look at the back, you can see that there is a kyphus or angle on the back, and this has definitely consequences on the spinal cord and the nerves which are getting out, giving you the paraplegia of Pott's disease. Okay, and then other areas are affected, like pericardium. It can be affected by extension, local extension, or by primary. It comes there and causes you pericardial effusion, and if it becomes tense, it gives you cardiac tamponade. Okay, the common disease of tuberculosis is obviously lungs. What happens in the lungs? In the lungs, we already have the primary, and we settled with that, the primary, and there is just the scar of the primary with the lymph nodes. That's it. But when it blares up as adult tuberculosis, then there is predilection to the apex. So the disease starts in the apices of the right and left lung, usually left lung, okay? And it becomes, a systemic disease, with fever, then cough, emaciation, and then you get very thin and loss of appetite, wasting, and cough. Cough is an important feature. And cough with mucopurulin, and if the granuloma eats up or opens up a vessel, then you get hemoptysis. This can even be an arterial and small arterioles, and the hemoptysis can be so severe that the patient loses his life by hemoptysis. So it is cough with either dry cough, it could be dry initially, or mucopurulent, or with hemoptysis, or with frank blood. Okay, so that is one area of affection, the pulmonary, and this is very common. Then it depends on the extension. Usually in the upper area or the apex, you can have a cavity, you can have an abscess, tuberculous abscess there. You can have healing by fibrosis. All right. Healing by fibrosis. All right. And gives you fibrosis. Unfortunately, the cases seen by the students, as far as tuberculosis is concerned, are those advanced. They have either cavities, very large cavities in the lungs, both lungs, or fibrosis, which is pulling the trachea, or collapsed lung. And these are museum cases because it just demonstrates the clinical picture of trachea being central normally. But if you have fibrosis on the left side, then it gets pulled and the trachea becomes deviated to the left side. Okay. Cavities, all right, with bronchial breathing. Patients will obviously have bronchial breathing. So these cases are brought to the examination to demonstrate clinical signs. Okay, and obviously they are a source of cases in the examination. This is why the students may have a distorted opinion about tuberculosis. Now, tuberculosis is maybe that in the lungs you find nothing, just crepitations, all right, wheeze, that's all, because treatment is started early. Okay, and we hope in a country where there is very abundant treatment, we don't end with these museum cases. Okay, so it's important to take into mind that you can have tuberculosis without these florid pathological conditions of the chest and lungs. Okay, tuberculous meningitis is a very severe disease, and it's something which may end up with sequelae. The sequelae, if it occurs in a child, it's an adult tuberculosis in a child, then he may lose his eighth nerve and becomes deaf. And if he's younger, or even if he's 8 years and he loses his hearing, then he becomes, dumb and cannot learn. Okay, other nerves which can be affected by tuberculous meningitis is 3 oculomotor nerve, could be 6, which is abducent, but usually this is non-localizing, and 4 trochlear nerve. So the pupil can be affected, and the movement of the eyes can be affected, and the hearing can be affected. Okay, the classical presentation, obviously, of tuberculosis is the headache. You have headache, you have fever, you have pain, neck pain, stiffness in the neck. So Kernig signs will be positive. Okay, flexion of the neck will be positive, and the patient becomes irritable, and he may even have seizures. He may have fits. Very much dependent, the prognosis is on early diagnosis. So if you early diagnose, and in children, we start treatment even before doing a lumbar puncture. Okay, so and you have to differentiate between meningococcal tuberculosis or bacterial tuberculosis versus meningitis versus tuberculous meningitis, because the treatment is different. In tuberculous meningitis, you will have, if you do a CSF, and we talked about how to do CSF in the last lecture. The CSF may be yellow or clear. It has very high protein. It has low glucose, and it has cells, not very much, but at least they have cells of mononuclear type, lymphocyte type. Okay, so once this is diagnosed, then treatment should be aggressive. To catch up, not being complicated. Okay, and last time we said that lumbar puncture is still the investigation of choice when you have meningitis. You have CT, you have MRI, but these cannot replace a good CSF examination. Okay, that's tuberculous meningitis. We have already the lung tuberculosis and the bones. The bones is, as we said, it's a post disease. And in post disease, you may have erosion of the anterior part of the vertebrae. This is why the kyphosis, it usually starts in the intervertebral area and then eats up the bones of the vertebrae, leading to kyphosis, and it depends on the dynamic and the mechanical bending. The consequence of the nerves and the spinal cord depends very much on this mechanical bending. But it is known that it is not just the mechanical bending, because it's been shown that there is end arthritis of the spinal cord, which contribute to the paraparesis or paraplegia, which is associated with POTS disease. And if you do an X-ray, you can have the kyphosis very clear. The vertebrae has been so distorted and small and crushed, okay? And you may find a shadow by the side, which is a psoas axis. The psoas axis on the side of the vertebrae. The treatment is medical, okay? Very rarely, if there is an emergency of sudden loss of leg mobility, then people can go to surgery. But this is an as early as possible, so that you will not have any complications. Okay. Treatment is usually long, and I hope we will have a separate lecture on the rest of tuberculosis. Just to remind you that today this lecture we lost it. Anyway, do you hear me now?
Yes, yeah, bro.
Okay, so I didn't mean to make it in the 142 years anniversary of discovering of tuberculosis, but it just came as a surprise to me, and it is a good occasion, remembering those scientists, who made life easier for the rest of us. With that, I would like to thank you very much indeed for being with us, and I hope to see you next Sunday. And thanks to Arwa, who has been keeping track of these lectures, and very soon she will announce that they are all in the YouTube. Thank you very much indeed. Goodbye.